This is Mike Adelberg. I'm the Executive Director of the National Association of Dental Plans, and I have the great pleasure today of getting to spend a little time and perform a live interview with Garen Corbett. Garen, maybe you could briefly introduce yourself and CHBRP.
Okay. Good morning. Thank you for having me. My name is Garen Corbett again. And for those who are new to our acronym, there was a shortage of vowels at the time. So CHBRP stands for the California Health Benefits Review Program. And I've been the director for 12 years now and been with the program for 14 years. And I'll get into a little bit about the program, but I come with a state health policy background and originally, I'm from Massachusetts. I've been in the Bay Area of California since 2009.
Terrific. From one Bay Area to another Bay Area.
Yeah, from lobster to crab.
Terrific. Garen, as before we dive into the ins and outs of the work that CHBRP performed on loss ratio, maybe for the benefit of this audience, which will be larger than just California, can you talk
Sure.
with us a little bit about CHBRP and its history and its mission?
Sure. So the CHBRP, the California Health Benefits Review Program, has been around for quite a long time. For 22 years now, it's fulfilled its statutory charge of supporting legislative decision making regarding health insurance, generally health insurance, benefit mandates, or related topics. It's really this unusual bridge between the academic enterprise and research enterprise of the big public university in California and the legislature. There are other mandate review programs around the country. What is particularly unique about ours is not only the speed in which we do our work, but that we're also directly providing this for the legislature. Other states set up programs that are through the executive branch and are kind of at an arm's length from the legislative process. So we're directly operating at the behest and request of the legislature, and our role in the process is kind of baked into the laws that sort of and the policies that guide the legislature each session. So the program was launched in 2003, and it really brings this sort of marriage of really diverse areas of expertise: researchers, policy analysts, actuaries, economists, clinicians, public health professionals, all under sort of one virtual umbrella. Our core staff team, though small, offers a wealth of knowledge and experience and really drives each analytic team's completion of each report or study. You can imagine if you're doing these in typical academia, it would take a year or two to do these. We're doing these in 60 days or less. Sometimes we're doing upwards of 20 concurrently. Which is where I think some of my gray hair comes from. But we are supported by, again, about 40 individuals who are affiliated with the CHBRP program across the university. And these are faculty members, researchers, analysts, and they're each bringing their unique areas of expertise. Some members of these 40, and again, we have like 1 to 5% of these people's time. It's really focused in the spring. Some members are writing, others are advising and reviewing. And we compress 2 rounds of peer review in each of these 60-day or less timelines. So it's a real sort of machine that we have to run, because if you're working on process, you're sort of dead in the water. Just a couple other sort of points about the way, because this is sort of kind of hard to envision. We operate independently from the University of California. Like many other public university systems, the University of California operates its own health system. There are 10 hospitals, 5 academic medical centers. We are very distinct and separate from all that. Our funding is derived from an assessment that is held in a state fund, and that really helps ensure our autonomy and objectivity. While our reports may not be thrilling, we don't use adjectives. So if you're having trouble sleeping at night, for 14 plus years, when my wife can't sleep at night, I sometimes will read from a report, and it works really effectively. However, it's really a testament to our unwavering dedication to neutrality in every bill analysis. So not putting adjectives of saying this is, incredibly expensive, or this would have, it's really the facts, and not to shape the debate to really equip stakeholders on both sides or 12 sides of an issue to use our work as sort of the accepted baseline. Our aim is to raise the bar for informed, evidence-based policymaking. And I will just sort of close by that sort of intro by saying it's a remarkable group of people who are drawn to this kind of both stressful and real world impact kind of work. So anyway, thanks for the opportunity to give a little bit of a peek under the covers of what CHBRP is.
Well, thank you, Garen, and thanks for the important work that you get to oversee at CHBRP. I will take issue just a little bit with the inference that your reports are not exciting. I can tell you we knew CHBRP was working on this report, and certainly at NADP, and we were absolutely waiting with bated breath for the report. So
I appreciate that.
But tell me, you also mentioned that most of CHBRP's focus has been on health insurance. So dental insurance, as you know, is different in many ways. What would give people confidence that CHBRP has the qualifications to take on dental insurance, and what other maybe oral health related topics have you analyzed?
Sure. That's a great question. Let me go big picture for a second. The California legislature, like other legislatures around the country, deals with 2,000 plus bills each year. There is a lot of expertise, and there are some very savvy generalists in the state capitol among legislators themselves and hundreds of legislative staff that support them. But there are a finite number of people who are deeply versed in the nuances of insurance, or have the capacity to deal with bills like the one that we're talking about. And stakeholder groups, of course, have an essential role in the legislative process. Much critical information and valuable fiscal estimates come from stakeholder groups, from lobbyists and advocates, and they're absolutely necessary to policymaking. But generally, they are not being assembled or developed by neutral parties. And CHBRP is designed to be neutral, objective, and evidence-based. And on a sort of a controversial issue like this, I think that was something that the legislature was looking for. But I will say we also approach every topic from a position of humility. That said, diving into complex technical issues is what we do. We're set up to focus on the insurance space. And so on this topic, we leveraged our partnership with our actuaries. We also completed a very careful review of all the available literature and studies that we were able to use. And we were able to make use of the extensive dental plan filing information that has been collected by the state of California. And that is a crucial key to being able to do this work. I will add, like earlier in my career, I oversaw dental plans for a significant public sector purchaser. These factors and the work that our actuary also did on these very particular issues, I think gave us reasonable confidence to navigate, in all frankness, right, tricky waters. I mean, this is very tricky stuff, and the deadline that we had to do this in 60 days or less is intense, but it's really sort of what we're set up to do. We have worked on some other dental benefit mandate bills in the past, even in the last session before. It's not a primary area, but I think we felt like we had the confidence, and the legislature really was hoping that we would give this a go.
Okay, I appreciate that. So then as a follow-up, we're going to get a little more specific now and talk about Assembly Bill 1048, and which would have, if passed, created an 85% loss ratio for dental plans in California. Why did CHBRP take on the study?
Well, first, why we were asked, we were requested, but are you sort of looking at sort of what were some of the key findings that we found, or sort of?
Well, I guess just were you directed to take on the study?
Yes. I mean, so there is a not to sort of go off into too wonky of a space, but the way the University of California is set up, it's almost like a fourth branch of government, the way it's set up constitutionally in California. So the legislature can pull the purse strings, they can request, but they can't direct anything.
Okay.
Of course, they can take away your funding the next year, but they can politely request. But yeah, we were absolutely requested. I mean, there is a little bit of informal back and forth, of course, that goes particularly in years where there's a lot of bills. But in general, when your client is the California legislature, when they are asking you to do something, we move mountains to make that happen.
Okay, appreciate that. So the report itself, when I reviewed it, what really caught my eye immediately were the projected premium increases
Yeah.
associated with the potential application of an 85% loss ratio. Can you talk about what drove projected premium increases of that size?
Yeah, I mean, the sort of going back for sort of, why don't I sort of talk about the primary findings, because it's a piece of an important piece of all of this, and there was a lot of context setting that we needed to do. In part, we're always, I spoke at the beginning about how our readers, are savvy generalists, but they tend not to have deep technical expertise in all of these different areas because there's hundreds of different public policy topics that they're dealing with. And so in this one, we really tried to take a little bit more time to set the context about, how are dental insurance benefits designed, and overlaying this with some fundamental facts about oral health. In our work, we typically try to help the legislature understand the context, because we want them to understand, okay, if you're moving a particular lever, what is the impact of that? But for this one, we really sort of had to take a step back and say, okay, first, dental services equate to about 4% of total healthcare spending in California. So it's like, okay, of the big universe, which galaxy are we talking about? Now we're here, right? Because it's all sort of in this sort of cloud of healthcare, and the constituents are complaining, and what are we even sort of talking about? And we also had to explain that fewer people have dental insurance than health insurance. That's sort of, for your members, that's a well-known fact, but for legislators, so again, to sort of really sort of get them to focus in on what we're talking about here. But then, we did a little bit more of a history lesson about, the forms of MLR regulation, and, how in some ways, this has existed at the state level back since 1980, although they were used for different purposes. They were kind of more about, used to assess and compare insurer value. The MLRs required of health plans are feasible in large part because of the Affordable Care Act and the way it standardized benefit design in health insurance by, of course, requiring the 10 essential health benefits. Congress established MLRs to provide greater transparency and accountability of healthcare expenditures made by health insurers, and of course, to drive down the cost of healthcare. That is a different use of MLRs than what we had before. And so, as we went through it, so much thought went into what Congress did in the ACA, which I know saying the words "what Congress put a lot of thought in" may not jump to mind, but there was a lot of technical input in that process. They use 3-year experience periods, which is really important for the fluctuations that you might see, which you see in health insurance, not to mention you see greater year-to-year fluctuations, of course, in dental insurance. They excluded quality improvement activities and they excluded taxes. And they also established minimum MLRs of 80% for individual and small group medical plans and 85% for large medical groups. And dental plans, of course, were explicitly exempted from the ACA's MLR rules and requirements. And so we really set this up as essential context, because if you're looking at sort of the illustrative example, in a vacuum, you're not sort of connecting all of these important pieces because you think, oh, well, we know about MLRs and health insurance, so shouldn't it work over here? And without sort of, expressly giving our recommendations, we try to overlay this with really important context, at least to leave breadcrumbs for important considerations that we thought they needed. And we also noted that, while some states were already requiring reports from plans on MLR rates or studying or considering the broader issue, going into this report for California, we really didn't have any concrete experience yet from any state to base our fiscal assumptions. And I'll get back to that in a moment. But as you all know, Massachusetts already passed by voter initiative an 83% mandate, but it wasn't yet in effect. So although we could hear, rumblings of what a few plans, were thinking about or were withdrawing from that market, we didn't yet see the implementation yet. And so we really couldn't draw much on Massachusetts. So returning back to my emphasis on CHBRP, again, operating with this spirit of humility when we take these on, we took pains to offer a reasonable illustrative scenario versus one stamp of this is our fiscal estimate. Confidence is one thing, hubris is another. The impacts of this proposed legislation had more, significant potential ramifications on state-regulated insurance market than the average piece of legislation or benefit mandate that we look at does by a long shot. I mean, we are sometimes out 3 or 4 decimal points. This is not that case for sure. And, again, in our conversations with ledge staff, and frankly, even on the author side, it's kind of sounded rather mundane to a casual observer. And we believed that this bill really had very high potential for considerable disruption. So we noted in the report that there were uncertainties, and, we noted, again, sort of trying to draw on evidence in the literature that insurance marketplaces tend to create, uncertainty creates more uncertainties in underwriting, which of course then potentially drives up premiums, impacting premiums and enrollment in dental plans over the long term. In turn, higher costs tend to, influence the utilization of oral health services, as you all know. And of course, delays in care, mainly, things like routine treatments and prevention, in turn may further increase the costs of oral health treatments. And then that trickles back again to insurance premiums. So we tried to bring this full circle by noting that dental insurance is essential to a person's decision to seek and use dental services. And previous studies that we're able to cite have shown that people with dental coverage at all income levels are likely to report actually having had a dental visit when they have dental insurance coverage. So, and then, of course, thus, poor oral health status leads to impacts on overall health and other health correlations, of course. So we really, not only given the illustrative, and we'll go into some of the premium impacts and so forth, but we really, this is unusual for us for really trying to spell out this full circle. And it's as close to a blinking yellow light as we can as a neutral, source of information to the legislature go. But we really took some pains here to adapt to the unique bill that we had before us.
I really appreciate that broader context, and I thank you for taking a second to do that. And with that, then the turning your attention to some of the more specific findings, whether they be premium increases or anything else, are there sort of specific findings that especially created that blinking yellow light?
In our scenario, we projected some significant increases, but we were going for reasonable assumptions, and an argument could be reasonably made for even higher projections. How the market would respond, of course, was what is it, the $64,000 question? That used to be a lot of money, I guess. Back in the 70s when that show was around, that was like, $2 million. But our task was to establish reasonable expectations, and again, that was a difficult assignment. The CHBRP team that worked on this speculated that many things were likely to happen simultaneously, and that added to what already was a high degree of unpredictability and uncertainty. Some anticipated impacts, but I will say, again, in the spirit of balance here, some anticipated impacts could potentially have met the legislation's intent in some segments of the dental plan market and their enrollees. For example, some of the less efficient plans might have exited or might exit the market we projected. And as we noted in our report, some plans were fairly close to meeting the 85% MLR ratio. However, other market segments and dental plans with various market share sizes in California faced extraordinarily high hurdles. See, I used a adjective, but particularly individual and small group plans and small to medium insurers. Uncertainty and market disruption, again, tend to increase underwriting costs. And since many individual enrollees and small group sponsors that we found are very price sensitive, they most likely would have dropped dental insurance coverage. And this in turn could have further destabilized the financing of these dental insurance products. And we found that given the enrollment size of many of the individual and small group plan products and the very limited administrative cost levers to pull, the proposed MLR ratios were not feasible without dramatic premium increases. In aggregate, 44% for dental PPO products and 166% for dental HMO products. And I think that made the case for the potential of very significant disruptions. And I think once the committee saw those estimates and the bill author's office, the bill was sort of put on deep ice.
Yeah, thanks. I appreciate that. So we know then that the bill was withdrawn. And I know you're not a politician. I know you don't have a seat in the legislature, so I certainly don't want to in any way put you in an uncomfortable position. But what do you think might happen next?
Yeah.
Could we see another version of the bill? Could we see something else?
It's a great question. I need to polish off my crystal ball. It's somewhere in the office, but I mean, in all seriousness, there are so many wild cards in politics and policy right now. The dynamics of what happens in the federal elections in the fall, and here locally in California, the status of California's current budget challenges have so many ripple effects that could really alter or, what the legislature has bandwidth for in their areas of focus. We also have another crop of new members coming in. California, not too many years ago, passed term limits. So we've seen many of the most sort of experienced members of the legislature term out over the last 6 years. And that has a ripple effect of, how quickly newer members take up some of these issues or go, look back to see bills that were or are bringing in, very different ideas or priorities. So I guess, but on the other hand, there has been a push nationally. There is, there are templates of legislation out there among other states. So I think I would give it a slightly better than 50-50 chance of this coming back in the near future, but I don't think it's at the high end of the priority. But I don't have, but I think it's high enough of a priority, and there's enough activity among other states that I think there's a decent shot of it coming back.
Okay, appreciate that. You've been, of course, very generous with your time and good thoughts. So, if I could trouble you for maybe one more question.
Sure, sure.
So, what knowing that Jaburp's purview is California, um, but also knowing that some of the trend lines and the overall market dynamics that you observed in California may very well have uh, some bearing and be at least somewhat instructive to other states. If you were contacted by colleagues in other states, um, what might you advise them in terms of the generalizability of your study and its projections?
We do from time to time get calls from colleagues in other states, and we do see our work cited in other states' analyses, and we occasionally reach out to other states. I do think that the approach and logic that we set out is replicable, and I do hope other states who are weighing in this, make use of this report. I mean, we participate in this subgroup of Academy Health, trying to both increase the capacity of states, Medicaid programs, executive branches, and legislatures to work with their public universities. We try to build capacity in this space. So many times people doing state health policy are trying to recreate the wheel. And it's like, if you at least, start at the 10 or 20 yard line with some work done by another state, it gets you out of the gate. I think many of the dynamics that we described in a report and projected for California are generalizable, even if the particular estimates are, of course, sensitive to each state's specific dental market dynamics. I will say having MLR data for insurance products across the market segments is absolutely critical. And you need to do that over some period of time. Again, with those year-to-year fluctuations, I think 3-year smoothing makes a lot of sense. If you're reliant on annual filings, then at least, have them for 5+ years, and you can sort of smooth out those ratios. If you are operating in states that are not yet collecting this information, or has required you to collect or submit that information, I might suggest that, at the association level, you may want to, for each state, you may want to start collecting that data. So California has a very big, diverse, complex economy. Other states may have less complexity. In fact, for anyone doing this analysis, I hope for you do have less complexity. But I think folks could use this report as an initial model and use many of the same considerations and logic that we put out there in terms of this scenario, and apply your own calculations or your own variables to it. But I think one can take it and walk with it, and at least as a starting point.
That's great. So, Garen, again, thanks so much for your good and important work at CHBRP. Thanks so much for being so generous with your time and thoughts just now. And certainly, if there's ever anything that NADP can do to make your job just a little bit easier, just let us know, and we'll certainly help in any way we can.
I really appreciate that.
Want to thank you again for doing this with us. There will be a couple of links on screen now, including a link to your report and a link to some of NADP's resources on loss ratio. And with that, I think we're wrapped up. And again, my thank you.
Thank you for having me. Appreciate it.